Hi everyone, welcome back to my channel. Today is going to be a little bit unusual video. So I will be teaching you guys how to do a progress note. Well, I should say I will be sharing with you my experience of how to do the progress note. This idea came to my head when one of my friends told me that she got so much of different information from different nurses and teachers at TAFE. She's doing a diploma of general nursing, about how to write a progress note, and some people would say do not include that, some people would say do include this, some people would say only write about abnormal things. So she was a little bit confused and she was asking me about my opinion, how I do my progress notes, and this is how I kind of like got this idea for this video, because I think a lot of people are actually getting confused about the progress notes, especially in the beginning when they just start their nursing career, or if you are a student and you go on a placement on a practice and you feeling a little bit lost in what to put in your progress note. So this video is going to be a little bit different in terms of how I filmed it. So I will be filming myself here on a phone, so you could see me visually talking to you, and then I will place myself somewhere in a corner of this video, and I will be also recording on my computer screen where I will be typing for you. First of all, stay patient with me because I'm not a fast typer and I do mistakes as well, so I will be fixing them up. I want to teach you, I want to share with you how to do 3 different types of progress notes. First one will be like a general progress note, which is like the most common one that you will do on your daily basis. Second one, I want to share with you about a patient who has been discharged through your shift. And the third one is going to be admission, when you have received a patient during your shift, okay? So let's just put on my, actually it was already recording, so let's just start from a general progress note. Okay, so the way I start my progress note is I write nursing entry, just short like this, NE. You can write nursing entry as it is if you want. So I just write NE, and then I start patient alert and oriented to time and place. If patient is not alert and oriented, if it's an elderly patient who has some sort of infection like UTI, sepsis, usually this is the most common causes to be not oriented but confused, okay, or even have delirium. So you will write patient alert but confused. Or you can say pleasantly confused if it's just a normal dementia, if someone came to you from nursing home. So you can say, but pleasantly confused, okay? Then I would say, I would start by writing about my QADs. QADs, it's your total score of your vital signs on your OBS chart, your observation chart. So your heart rate, your temperature, your respiration, your SATs, your blood pressure, and so on. You just put them all as a general total score. So I would say QADs equal, let's say 0, and then I would say nil means no, complain of pain. So this is abbreviation here. A lot of nursing staff and medical people as well, they love to use abbreviations, okay? So you will find doctors use abbreviations, physios, speeches, nurses. Don't get frightened about amount of abbreviations that they use, and some of them look really weird. And up until today, like, I sometimes read the progress notes from the doctor, like it's not a progress note, but it's more like a treating plan and observations and stuff. It's still a progress note in some way, but like the way they use abbreviations and their font, like it's literally like a chicken scratch. You can't understand anything. But I think the doctors use the most of abbreviations, and this is where I used to struggle in the beginning a lot because I couldn't understand what they meant. So I needed to grab nurses from the floor just to explain to me what that or this abbreviation meant, because I needed to know what the doctors mean in a plan, because when I need to give a handover to the next staff, I need to know what is the plan of my patient. And sometimes when they use abbreviations plus the chicken scratch that they use in writing, was a complete disaster. But anyway, I've learned some of them, and the more you practice, the more you memorize, obviously. So nil, it means no. CO, complain of pain. If the person had pain, I would say Q adds 0. Patient complained of pain in their lower back earlier this morning. And then what intervention have you done? Remember, in progress notes, if someone complained of pain or anything, you need to write what have you done, what intervention have you done, how did you help your patient, okay? So I would say that patient complained of pain in their lower back earlier this morning. PRN analgesia was given with good effect. Okay, you can say PRN analgesia, or you can say PRN endone, for example. 5 milligrams was given with good effect, okay, if you want to specify what type of analgesia you gave. Okay, if the Q adds, let's say, are not 0, let's say Q adds equal 1, I usually specify 1 what? Is it 1 in blood pressure? Is it low or high? What is it exactly? So I would say, for example, due to blood pressure being 100 over 65, I think 100 would be scored in still 1. And then again, what did you do? So I would say TL, which is team leader, notified, and patient was encouraged to drink more fluids. Because usually the easiest way to bring the blood pressure up is to drink more oral fluids. Just make sure that your patient is not on fluid restriction. If they are, just make sure that they are drinking fluids in that restriction amount. Usually they're like 1.2 liters, 1.5 liters, so make sure you don't give them more than that every 24 hours. And make sure that the person is tolerating actually fluids okay, you know, drinking okay, if someone is not on NG tube and stuff like that. Okay, and then I would say patient asymptomatic, which means the patient doesn't have any symptoms like feeling dizzy or lightheaded when they get up going to toilet, so they're not gonna fall. Okay, then I would say that patient tolerated meals, or just say food. Patient tolerated food well. If someone is on full assistance, for example, if it's an elderly person from aged care facility came to your ward and they can't eat by themselves or just need a setup, all of this will be in a care plan. But let's say if someone is on a full assistance, I would mention it here because this is something that doesn't happen every day to all patients. So I would say patient tolerated food well, however needs a full assistance with feeds. Okay. Oops, stay. Needs full assistance with feeds. Then I would say meds administered as per chart, and I would say patient prefers tablets to be crushed. Okay, prefers, there we go. No, yeah, patient prefers tablets to be crushed. This is something that is unusual, for example, so I would mention it here. Then I would say skin intact, IVC, let's say the cannula, if someone has a cannula, IVC in situ, dressing intact, flushes well. If you've been given, for example, any IV medication throughout the shift, so you know it's flushed as well. Then I would talk about mobility. Patient, you can say the patient was assessed by physio, was assessed by physio today. Oops. By physio today, and you can put mobility unchanged. Okay. Or if the patient hasn't been assessed by the physio, for example, you can say patient mobilizes to toilet, 1 assist with Willy Walker. Okay. Then you can say bowels not open, which means BNO in abbreviation way. Bowels not open, bowel chart in place. You can say bowels not open, let's say 2 out of 7, 2 days out of 7. Bowel chart in place. If someone has a pressure injury, let's say, this is very common, especially for people who are elderly. And the most common place for them to have pressure injuries are in the sacrum. So you can say dressing on the sacrum was changed today. Intact. And you can put in brackets pressure, you can say old pressure injury stage 1, but it will be all in charts of the patient blue folder anyway. Okay, then what else you can say? That patient usually when someone has like pressure injuries, that would be someone who would be like staying in bed most of the time. Okay, so let's just remove the patient was assessed by physio today, mobility unchanged. Let's pretend that this was for different patient. Let's say bowels not open, bowel chart in place. Someone who is with pressure injury would be not moving much, so they would get constipated quite often. So you would say bowels not open 2 out of 7. Let's make it a little bit worse. Let's make 3 out of 7. Bowel chart in place, and you can say that regular laxatives given as charted. Okay, so regular laxatives given as charted. Dressing on sacrum was changed today, intact. Old pressure injury stage 1. Sometimes it's important to mention that it's old, because if we didn't see pressure injuries on admission for someone, or let's say if it was in-hospital transfer from a different ward to us, and we've looked in a care plan and there is no any sign or a mention about pressure injury, and we were changing that person later on and found that someone has a pressure injury, okay, it's always good to document it, because if the pressure injury was gained for the patient while they are on a ward, okay, that's a fine. Okay, I think it starts from stage 3 or maybe 2, can't remember exactly, but we have to be really careful, okay, especially with those people who come from aged care facilities. A lot of them have pressure injuries, okay, so we need to document it and check the skin on admission. Very important to do that. Okay, so dressing on sacrum was changed today, intact, old pressure injury, stage 1. Then I would say, just thinking about head to toe, if the IDC in situ, you can say that IDC in situ, draining well, fluid balance chart, fluid balance chart, this is another abbreviation for you, in place for more info about output and input. What else we might have? Sometimes people have slings. You can say sling on a right leg in situ. Yeah, you can say that. In situ, patient likes to keep it on while in bed, or patient takes it off while sleeping, for example. Here, just remember something. So dressing on the sacrum was changed today, intact, all pressure injury stage 1, patient on 3-4 hourly repositioning. So that would be another kind of like intervention for you and for other people to do. When someone has a pressure injury and mostly staying in bed, make sure that that person is on repositioning schedule, because you need to make sure that that pressure injury is healing rather than deteriorating. Oh, it's always hard for me to say that word. Rather than just becoming worse. Okay, so IDC in situ, draining well, fluid balance chart in place for more info. Okay, or you can say just fluid balance chart in place. I'm getting tired. It's 10 o'clock at night. 10:15. What else I would mention in my progress note? It depends on the situation, what's happening. If someone had a fall, for example, you would say that patient had a witnessed fall while being in a toilet. Neil had heat, for example, OBS obtained within the normal ranges. Patient, let's say, complained of right hip pain, awaiting imaging. Okay, because most of the time patients will be sent for images, especially if it's unwitnessed fall. They will scan their head as well, making sure that they don't have any internal bleeding. Okay, so you can mention that, and you can also mention that patient now is on neuro-obs. What else? What would be other things that you would mention? Just like a general progress note. I think that would be it pretty much. You can then say in the end, nil other concerns voiced at your on a time of check. Okay, by patient, and then you finish your note by putting your initials, YS, and then RN, and then would be your signature. That would be your signature there. Okay, then I usually put a line like that, so nobody can add anything. So that's your kind of like general progress note. You always go off what's happening on a shift. Okay, if it's something abnormal, you would add it in. Okay, second progress note would be when you have an admission. Okay, admission. I'll just make it bold. On admission. So on admission, I try to do progress note as fast as I can. So once the patient came in, I've taken the handover. I've orientated patient to the place. So I showed the baza. I showed how to use the TV, and gave jug of water, and stuff like that. And then I will do my admission papers, and I will go through all the questions and everything that the patient needs to answer, all the paperwork. And then after that, I'll do my progress note. If this patient came, let's say, from the ED, okay, I will do the full skin assessment. I would ask patient if they had falls in the last 6 months. I would ask if they know their weight. If not, I'll try to weigh them, depending on how they feel. If it's something like if they're in pain or uncomfortable, I would leave them just for that moment. But if they're able to, tolerate to weigh them, I can do that. Then I will ask what was their mobility at home, just to confirm what was given to me on a handover, just to make sure that it is the right information, and put it all in the notes. And then my progress note would be nursing entry, and I would say patient alert and orientation orientated, Q adds equal 0, new complaint of pain. Okay, let's say meds are not given yet. If someone came from ED, this person will be admitted, which means one of the doctors will need to come and chart the medication. Okay, so I would say new complaint of pain, skin intact. Oh, sorry, I would say here, because it's admission, I would say patient alert and orientated, arrived to ward at, let's say, 17, Q adds 0, arrived at ward at 17, Q adds equals 0, new complaint of pain, skin intact, skin intact, patient waiting for admission by treating team. Okay, let's say patient brought meds with them. I would say that schedule A meds brought by patient was locked away, were locked away. Then I would say that if the patient came, let's say, after a fall, I would say patient resting in bed, referred to physio for mobility assessment. Okay. Because sometimes you might have someone who came through ED to your ward post-fall in aged care facility. So in ED they could have done maybe some of the imaging, or they send them up to us for medical observations, just to observe them, maybe treat them with some analgesia if there is any fracture or if they experience pain somewhere, and then more imaging will be scheduled, and then they will need to wait on a ward with us to see the results of the imaging as well. Maybe someone had as well like high blood pressure as well when they were in ED, you know, or abnormal QADs or whatever. So if it's not too high, they can send them to us for monitoring as well, you know. It depends. If the patient more or less not critical and stable-ish, they will send them to us. If the patient is critical, you know, and a lot of pain, or is abnormal, they'll send them to ICU from the ED. Okay, so I would say Schedule 8 meds brought by the patient were locked away, patient resting in bed, referred to physio for mobility assessment. I would say normal diet as per patient statement, and I would say tolerates free fluids or thin fluids well. Okay, diet, so I would say normal diet as per patient statement, tolerates free fluids well. What else I would say? Call bell given in reach. Nil other concerns. If someone came to you from another ward and let's say has a IDC in situ, so you would do the same thing. You would say that, IDC in situ, draining well, fluid balance in place, or you can say IDC in situ, drained, let's say 600 in total. Okay, 600 mils in total. So that would be your admission. As you can see, it's really simple. It's not difficult at all, okay? If something would be very, very abnormal, you will put it there and you will put the intervention, okay? If someone, let's say, came with diarrhea. Okay, it doesn't look like gastro, no vomiting, just diarrhea. You know, you would write in saying that bowels open, let's say 3-4 times. So bowels open, let's say 3 times. Loose, pad changed, patient incontinent, stool sample sent. Okay, because usually if someone has loose bowels consistently, a couple of times a day, a few days in a row, you know, usually you will report it to the treating team, and the treating team usually will give you a slip for the pathologist, so you could send a stool sample. Okay, so you would say bowels open 3 times, loose, pad changed, patient incontinent means like he didn't go to toilet, stool sample sent. Okay, so that's something like abnormal. And then you would say nil other concerns, and then you would sign it off, your signature, and the end. Then your discharge. Okay, your discharge. This one is like easy peasy as well. It's like your general note plus the discharge. So you would say nursing entry. I'm just gonna do this one really quick. Patient alert. Let's say patient was alert and oriented throughout the shift. Q adds were 0. New complaint of pain, meds given as charted, IVC taken out because he was going home. Treating team was happy for patient to discharge. Scripts given, because usually when they discharge, most of the time they would have some scripts given to them, meaning that they will have some sort of medication taken after discharge. For example, if someone had sepsis or UTI and that was the reason for administration to the hospital, person would be on some sort of antibiotics for IV for some period of time, and then when they become more or less stable, they would change to oral, and pretty much if they are still stable, they can go home on oral antibiotics. So for that, they would need script. Okay, so you would say treating team was happy for patient to be discharged. Scripts given, all belongings packed, family contacted to pick up the patient, and then you can say patient was sent to transit lounge. Family contacted to pick up the patient. Let's just ignore it all. To the transit lounge. And then you can just sign off. Easy. So discharge, you would mention that patient was alert and oriented throughout the shift. QADs were 0, nil complaint of pain, meds given as charted, IVC taken out, treating team was happy for patient to be discharged, scripts given, all belongings packed, family contacted to pick up the patient, patient was sent to the transit lounge. Usually, you would not have much of abnormalities or nil abnormalities in a progress note for someone who is discharging, because in order for them to be discharged, they should be stable, they should not have anything abnormal or any incidents and stuff like that. So your progress note is going to be very, very basic, but you will need to say that, for example, any devices being taken out. If someone is going back home on oxygen or with a permanent IDC, or NG tube. Obviously you will mention in that the patient has in situ NG tube, NG, or you can say IDC, permanent IDC, or oxygen. You can say that the patient will go home with it. If someone was on 1 liter of oxygen and that was the only thing that was holding them in a hospital, and the team wanted to wean it, and once they of the oxygen, the room sets sitting above 94 or 95 as per request of the treating team. So you win the oxygen, the sets are fine, you know, then they can go home. That's the plan. The team happy for the patient to go home once the sats on the room air above 94 to 95 and above. You can mention this in a progress note. You can say that patient, you can say O2 has been weaned, patient on room air sats 95, treating team happy for him to go home. Okay, so you can mention that in your progress note. So this is it, guys. It's pretty easy. It's not complicated at all. You don't have to make your progress notes big, okay, unless someone has been abusive to you, or security needed to be called, you know, or patient had unwitnessed fall, you know, or refusing medication, you know. Again, it's all about your interventions, what has been done, okay? If someone has been abusive to the staff, you can write that and then say that security has been called, you know. What happened after that, you know, how did you help the patient? Was patient being able to be reassured and approachable to talk to calm them down, or the patient was aggressive to the point that you needed to call the security? So you can mention that. As I said, if someone had a fall, if someone had a med call, okay, you will write it in a progress note as well. You can say that the patient had a med call this morning due to elevated respiration of 35 or 36. That's already on itself is a med call. And you can say that you don't have to go like into much of details about the med call, because when usually med call happens, there is someone who will be scribing, who will be writing in a special form for the med call what has been happening. Plus the treating team will put their progress note as well right after the med call. They will write the findings, OBS, and then the treatment plan for that person. Okay, if the person is staying on the ward and is not going to move anywhere, if they became stable, if they gave them some sort of medication throughout the med call or whatever, you know, and sort it out. So you can write it in your progress note just briefly. Do not go into much of details. As I said, everything will be in charts. So I hope this video was helpful, guys. I tried to make it as simple as possible, and I tried to make it not too long. It's like half an hour now. But if you have more questions, please ask me in the comment section below. If there are nurses who are beginners, who just started their career in nursing, first year or whatever, and you have something to add, if you have more ideas or more information to share about how you write progress notes, please leave it in the comments section below. I think we all will be happy to read it and just see other ideas and other perspectives on this topic, because it's always good to share information, you know, and learn from each other. So feel free to add something from your side as well. And yeah, I hope this video was helpful for you guys, and I'll see you in my next one. Bye.